Yeah, good morning. So on Monday, Dr. Fraha gave a talk about our first pillar, which is our treatment pillar. Antje gave a talk about our second pillar, prevention and early detection. And now our last pillar, palliative care. I want to give you an overview of what we have done so far at KCMC. I will start with an overview of palliative care in Tanzania, but especially also at KCMC, and then our steps to re-establish palliative care and some data from our first patients we have seen so far from end 2016 up to April this year. If we look at palliative care from an oncology perspective, as we heard several times in this conference, around 80% of our patients come late in stage 3 or 4. The incidence rate of cancer overall, according to WHO estimations, is 123 cases per 100,000, which leads to 62,000 new cases, cancer patients annually, and it's 50,000 new advanced cancer stages annually. If we look at the publication von Fliss et al., it's in high-income country, but they said 69% of people who die need palliative care. If we take those figures also into Tanzania, it means we would have 34,000 new cancer patients in need of palliative care every year. If we look at palliative care from an internal medicine perspective, because it's not all cancer that need palliative care, I would like to give you these figures from our colleague Dr. Lewis from UK. She did a survey beginning of 2016 at KCMC, and 59% of all inpatients on the medical ward suffered from life-limiting diseases. 30% were cancer, the rest were other diseases than cancer, advanced lung diseases, heart diseases, liver diseases. And accordingly, the WHO global health estimates speak about 178 to 270 cases per 100,000. This is the need of palliative care in Africa. And for Tanzania, it means annually new cases, 90,000 up to 136,000 cases that need specialized palliative care. This is a huge number. The reality of palliative care in Tanzania in 2016, most of the hospitals had lack of opioids in the majority of healthcare facilities. In 2010, only 4 hospitals hold the license to dispense morphine. This is now much better, but that is not so long ago. And we know that there is a low prescription rates in opioids. It's also connected with a lot of misbeliefs in opioids, lack of trained professionals, and especially there is no financial sustainability in palliative care. This is due to, let's say, the lesser burden in HIV/AIDS. During the 90s, when the HIV/AIDS epidemic peaked, we had a lot of palliative care teams all over the country, and the funding were there. But now that this is not so much more a problem because of the good treatment opportunities, fundings for palliative care teams went down, and many of our teams in Kilimanjaro region, they really struggle to pay more than 1 or 2 full-time staff, and not like in the past when they had a lot of community health workers going out into the community. This funding has dried out. So in 2016, this was the situation at KCMC. There was a palliative care team established in 2007. It was a multidisciplinary team, but there was no single staff allocated full-time for palliative care. So everybody did it on top of their normal duties. And there was no funding for palliative care. The morphine procurement was problematic. The only morphine we can get, and still it's from Ocean Road, but at this time our pharmacists had to travel from Moshi to Dar es Salaam to get 5 liters of morphine and then come back. 5 liters of morphine means 10 bottles of morphine. One bottle is 500 milliliters, 500 milligrams. It lasts probably 1 month for one patient. So going forth and back to Dar es Salaam to get 10 liters, 20 bottles for 20 patients, this is just not efficient, and we just didn't do it. Yeah. So a basic training was provided at this time for about 30 members and staff from KCMC. Accordingly, the situation on the wards in 2016, and I come back to Dr. Louis' small survey, she looked at 124 patients on the medical ward, 59 with the life-limiting diseases, and patients with at least one analgesic drug, 20%, patients with 2 analgesic drugs, 6%, and as I said, patients with morphine, because it was not available, 0%. From these patients, 5 had the worst pain level. We used the APCA pain level 1 to 5, not the international 1 to 10. And 5 of those patients had pain level 5, and 0% had morphine. And palliative care trained staff, as I said, we had 30 of them, 0% were seen by those 30. So what is the present situation at KCMC? With the establishment of our cancer care center, palliative care became, is one of our pillars, again, a very urgent topic. And we agreed on these priorities. First and utmost, we need to have the availability of oral morphine and essential drugs at hand. We want to provide training for KCMC and other surrounding hospitals. This is very important as a referral hospital, that you know where to refer your patients. If you see they need palliative care, you can't treat them on the spot. They need to go back to their home villages, to their district hospitals. So we wanted from the beginning to involve the district hospitals as well. Home-based care, that was our idea, to implement it quite early in the process and to conduct palliative care ward rounds. As Dr. Furaha said on Monday, we conduct this as a combined oncology and palliative care ward round every week at KCMC. So the present situation at KCMC, we have oral morphine, as you can see on the left side. It's still in empty water bottles, but marked as morphine. And we have other essential drugs are available, and we have distributed them also to other hospitals in the region. We do frequent home care since October 2016. We trained 21 staff members from KCMC and other hospitals. And that was probably the best achievement so far, we trained last year in November 23 community health workers from Moshi, and they got an extra training on their basic medical education. So they are now going out into the community and see the cancer patients at their home, and they are also allowed to distribute pain medication. If they want to distribute morphine, they just get back to our palliative care nurse and they get their permission for this. As I said, we have the weekly combined oncology and palliative care ward round, also to ensure early integration of palliative care in our patients. And right now we have fundings around $20,000 per year from a German mission. And now I want to present you the first data from our patients that we have seen. These are the data from the from January 2017 to April 2018. 334 patients have been seen, and 147 by the community health workers. So this is our new achievement since November last year. Mostly they were seen only by the community health workers, but if needed, they would call us and we would also go to their homes to see them as well. And 182 have been seen by the palliative care team in the hospital. Looking at the gender, it's females 55% and health endurance, and this is quite conclusive with what Antje told us. We have 31% of our patients under health endurance. It's a bit less than we have in our cancer care center. There's about more than 40%, but this is a quite nice number, even though morphine is not covered by the National Health Insurance Fund, unfortunately. The age group, As you can see, most of our patients are in the age between 40 and 70 years, and this is our first shortcoming. Especially the pediatric doctors under you will see, like, we are not focusing on kids. That is definitely our weak side, and we need to change this in the future to focus more on our pediatric oncology patients. The caregivers, quite interesting. It's mostly daughters and sons, sisters and brothers that care about their relatives. And I haven't showed you now the distribution of female and male. Normally, palliative care and home care is it's a female issue. It's the caring aspect of women. But we have a distribution of 60% women and 40% men. And this is the same in the hospital and also in home care. So that is also quite interesting. It's also a lot of men care about their sick relatives. And now, if we see at the diagnosis, we have 68% cancer cases and 32% non-cancer cases. And this is so far not very stunning, but look at this distribution. On the left side, you see the hospital palliative care team. We see almost only cancer cases, 96%. On the right side, you see the distribution among the home care and our community health workers, and they see the majority are non-cancer cases. And this is what we wanted to achieve. We deliver palliative care to all patients, not only to cancer patients, but our starting point was the cancer care center. So of course in the hospital our focus was on cancer patients, but as soon as you integrate community health workers, they will also see other people in need of palliative care that have other diseases than cancer. And this 39% cancer diseases is quite fitting to what Dr. Lewis saw at KCMC, that 30% of the life-limiting diseases are cancer and the rest are other diseases. So through cancer care, we boosted palliative care in Moshi also for other diseases. And then these are our cancer diagnoses in palliative care. We have breast cancer, prostate cancer, and cervical cancer. As Dr. Furaha said on Monday, we are missing the cervical cancer case at our center because we refer them directly to Ocean Road for radiation. But in palliative care, of course, we see them back if they have a relapse or if they never went to Ocean Road. And so I'm also a hematologist. That's why I also gave the hematology malignancies. We have some of them, and most of them are preventable or treatable, let's say, not preventable, treatable. So this is also something we need to work on the hematology side to have less hematological malignancies in palliative situations. Coming to the symptoms, on the left side, this is pain. The blue bar gives you both all the patients, and then we have the home care patients in yellow, and in green the hospital care patients. And you see they all have, it's a bit more than 50% of the cases, they have pain as their main symptom. And then we see the distribution. We have a bit more of gastrointestinal symptoms and respiratory symptoms at the hospital, and we have more immobility in the home care setting, which is quite understandable and normal to have this distribution. But another shortcoming, on the very right side, you see anxiety and depression. And this is not because they don't have it, it's just we don't record it. And this is one of our big shortcomings, and I think I can speak for all centers. We are lacking a good clinical psychologist on the sites, and this is a very, very weak discipline right now in Tanzania. We have to have more emphasis on psychologists, and I think this is, beside our pediatric focus, this is something we need to focus more also in the training and education of our workers. I will give you, as the last slides, an overview of the pain management. You see, these are the 5 levels from APCA, from the African Palliative Care Association. 0 is no pain, and 5 is the worst pain you can imagine. So this is pain level 1, 2, 3, 4, 5. And we had 257 patients with pain, and this is the distribution. So most of them were on pain level 4. And I checked in our data about the initial therapy, what they got. And you can see in level 1, I divided it to the WHO ladder. So WHO ladder 1 is a peripheral analgesic like paracetamol or diclofenac, ibuprofen. Ladder 2 is combination with a low opioid, and then WHO ladder step 3 is to give morphine. And you can see that the level 1 and 2 patients mostly have WHO step 1 medication, and the higher we go up in the levels, the more WHO ladder 2 and 3 stages they got. And then level 5, we had 31 patients with the worst pain, and all of them got morphine, either from the hospital palliative care team or from the community health workers. And I thought this is a super result, because if we go back to 2016, 0% of the patients at KCMC were under morphine, and now all of them who are really in need, they have morphine. So promoting palliative care through cancer care is an effective way to deliver adequate pain management, to use synergy effects in staffing and funding, to reach the community through community health workers, to use our community health workers for active case finding, cancer cases finding, this is also what we see, and to also deliver palliative care to non-cancer patients. Thank you for your attention.